I'm a psychiatrist working at the University of Tokyo Hospital, but because of the shortness of presentation time, I'll skip the self-introduction. So in this presentation, I like to elucidate epistemic injustice in the therapeutic relationship in psychiatry. I focus not on anecdotal problematic cases, but try to illuminate the background structure from which individual cases of epistemic injustice emerge. Especially, I'm going to show that epistemic injustice in the therapeutic relationship in psychiatry is predisposed by roles mental health professionals play in their relationships with patients. So I will describe the characteristic feature of the psychiatrist-patient relationship in 3 steps. First, because the psychiatrist-patient relationship is a kind of the professional-client relationship, I will see how epistemic injustice occur in the professional-client relationship in general. Second, we will see what is common to the relationship between physician and patient, but not specific to that between psychiatrist and patient. In the last step, what is specific to the psychiatrist-patient relationship is discussed. So let's move on to the professional-client relationship. So what is a profession? Profession refers to priests, lawyers, and physicians in medieval times, but the notion has extended to include dentists, accountants, veterinarians, clinical psychologists, financial planners, etc. in contemporary society. So roughly speaking, professionals help clients who bring their problems with their knowledge and expertise and live on the fees paid by the clients. So professional occupation is characterized by its specific epistemic relationship with its clients. Everyone who has an occupation is in a sense a kind of expert and live on the income earned for helping others in some sense. But not all experts are professionals. What professionals provide for their clients is not goods like retailers, not techniques like carpenters, not general knowledge like teachers. So I think the essential feature of professional service is private consultation. So successful consultation is based on a bidirectional informational exchange or epistemic collaboration between the professional and the client. So let's see what kind of epistemic injustice is prevalent in the professional-client relationship. So basically, professionals have a better knowledge than clients as for the subject matter of which they are experts. Therefore, professionals sometimes should deny credibility to the testimony given by the clients. But this is not a case of epistemic injustice. I find two types of epistemic injustice can happen. The first pattern is credibility inflation of professionals. For example, physicians are sometimes considered to know everything by the patients and families. When such credibility inflation exists, errors made by the professions are hard to detect, and it hinders open discussion between the profession and the client. The second pattern is epistemic smothering of the client, which is the notion proposed by Christy Dodson. If the professionals show insensitivity to the issues outside their specialty, the client refrains from revealing important information the client thinks as irrelevant. In addition, the client is often marginalized in the professional-client relationship. A soldier reports his findings to the commander, who integrates the information and gives orders. The soldier is not participating in the decision-making process. The professional-client relationship often resembles the commander-soldier relationship. The professionals judge the significance or relevance of the information given by the client and give an advice from purely professional point of view. Even if the client is considered a credible informant, professionals tend to overlook the relevance of the client's statement, and the client is precluded from participating in the epistemic collaboration. And this is a form of participant injustice, to use Christopher Fuquay's term. So now let's look into what happens in physician-patient relationship. Fricker considered that epistemic injustice is wrong because it objectifies the speaker and turns them into a source of information. Polhaus criticized that Fricker's usages of objectification is inappropriate for the explanation of the wrong of epistemic injustice in general. Nevertheless, I believe that the concepts of source of information and objectification are useful when discussing the epistemic injustice that arise in the physician-patient relationship. This is because the subject matter of medicine is the problem in the patient's body. When making clinical decisions, it is important to obtain objective information from the patient through physical examination, blood tests, etc., in addition to interviewing the patient about the history of illness. The patient is an informant when responding to a medical interview, but a source of information when receiving blood tests or CT scans. In contemporary medicine, physicians tend to consider patients' complaint subjective and put high priority on objective findings. But physicians put high priority on objective findings with reasons. The existence of objective findings is often decisive evidence for a medical diagnosis. There are occasions when a physician must deny the veracity of patient's testimony based on an objective findings. For example, if a patient with anorexia denies abuse of laxatives or self-induced vomiting, but blood tests show significant electrolyte abnormalities and elevated salivary amylase level, it is probable that the patient is lying. But this is not a case of epistemic injustice, but a reflection of empirical attitude. By contrast, when doctors find no objective signs that support the complaint brought by the patient, they tend to doubt the credibility of the complaint or dismiss it as irrelevant to the treatment planning. This can be a case of epistemic injustice. Nowadays, physicians often consider the report of the symptoms given by the patients with chronic pain and fatigue untruthful, simply because they lack supporting objective findings. And this might be a contemporary version of the tragedy of curare, because absence of evidence is not evidence of absence. Although subjective complaints lacking objective abnormality are not likely immediate fatal condition, they are important for the patient and should be considered veridical unless there is strong evidence to the contrary. So now I will focus on the psychiatrist-patient relationship. I will argue that psychiatrists sometimes objectify the utterance of the patients. So let me show the case of John, who was a university student. For the past 6 months, he had been unable to concentrate on the lectures, and his grades had started to drop. In the consultation room, John complained strenuously to the psychiatrist that the government was being taken over by a shadowy organization. He complained that he could hear many spies around him discussing things that only he should know about. The psychiatrist judged from his utterance that he had auditory hallucination and delusions, and informed John that he had schizophrenia. A few weeks later, after the initiation of medication, John was able to go out by himself. If asked, he still admitted that a shadowy organization was taking over the government, but he was no longer actively insisting on it. Based on these information, she concluded that the pharmacotherapy was effective. In this case, the patient's utterance is not regarded as a testimony, but a mere source of information that indicates he's having mental illness. In other words, the utterance is objectified. The psychiatrist judged from his utterance that he had auditory hallucination and delusion, and her conclusion that the pharmacotherapy was effective based on John's less insistence on the influence of shadowy organization, a typical example of objectification of utterance. So, the objectification of utterance looks very similar to epistemic injustice. So my question is objectification of utterance a form of epistemic injustice? And my contention is that objectification and epistemic injustice are independent, as shown in the figure, and there are both justifiable and unjustifiable cases of objectification of utterance. So objectification of utterance is justified when the following three conditions are met. Condition 1, empiricism. The objectification of the utterance is based on sufficient objective grounds. This condition is required for objectification of utterance not to be derived from prejudice against the speaker. Condition 2, benevolence. Negating the status as a valid testimony avoids the potential harm to the patient's reputation, property, or interpersonal relationships that would accompany if it were perceived as a valid testimony. And condition number 3, minimalism. The objectification of utterance is confined to the minimum extent necessary to compartmentalize the patient's pathological behaviors rather than covering all the patient's utterances. So I'd like to contrast two cases to illustrate the difference between justifiable and unjustifiable objectification of utterance. The first case is Ellen Sachs' own experience. Ellen visited emergency room owing to unusual and severe headache, but the emergency doctor did not offer a proper examination because she had been diagnosed with schizophrenia. As a result, her subarachnoid hemorrhage was overlooked. In this case, empiricism condition is not satisfied because the emergency doctor interpreted her complaints as a symptom of illness based solely on the information that she had schizophrenia. Second, benevolence condition is not satisfied in this case because it was done for the emergency doctor to avoid a time-consuming medical examination and treatment. Third, minimalism condition is not satisfied because objectifying her utterance based solely on the fact that she had schizophrenia would make it impossible to compartmentalize the speaker's pathological aspect. Therefore, Sachs' case is not justified, and her experience should be categorized as a case of testimonial injustice. The second case, which is shown in the right side, is presented by Sanati and Kiratsous. A patient with schizoaffective disorder complained of being attacked by a neighbor, which was considered a delusion and resulted in involuntary hospitalization, but was later found to be true. In this case, empiricism condition is satisfied because he had also irritable mood, pressured speech, delusion of reference from TV, etc., which indicate that he was actively psychotic. Benevolence condition is satisfied because the psychiatrist sought to prevent his potential assault on his neighbors and offer him psychiatric treatment. Minimalist condition turned out to be dissatisfied because the psychiatrist initially misconceived that his complaint of being attacked by a neighbor as a part of delusion, but it can be known only later. So I think that the initial judgment that his complaint is a part of delusion is justified. So I diagnose Sanati and Kiratsou's case as justifiable but excessive case of objectification of utterance. So here is the conclusion. I have described the characteristic feature of therapeutic relationship in psychiatry in 3 steps. As a professional, psychiatrists have an ample knowledge on medical illness and its treatment. But professionals' credibility excess and testimonial smothering of the patient makes the epistemic teamwork inflexible. And at the same time, psychiatrists often overlook the relevance of the patient's statement, which preclude the patient from participating in clinical discussions. As a doctor, objective findings sometimes justify the psychiatrist to negate the patient's testimony, but overemphasis on objective findings cause the negation of patient's complaints. And as a psychiatrist, patient's statement is sometimes considered a symptom of mental illness and utilized as a source of information. But objectification of utterance easily slides into epistemic injustice. And objectification of utterance is justified only when it is based on objective ground, done for the benefit of the patient, and done with minimal amount. So epistemic injustice in psychiatry is predisposed by the roles that psychiatrists play in their relationship with patients. And I think this is the start point for endeavors to overcome epistemic injustice in this field. So this is the end of my presentation. Thank you for your attention.